All right. So now that OB's over, we can move on. Psychiatrics. We are going to do mood disorders and suicide right now. And we are also going to do a couple other videos on schizophrenia, review of some basic things like tort laws. But right now we're just going to focus on mood disorders and suicide and see what we can get through in the next hour and a half and have these. I am going to link this so people can at least watch this if necessary. So, why don't we get started on this?
Okay.
So, remember, don't talk over each other. We'll just get through this one at a time. Mood disorders and suicide. It's manifested by depression, a mania, or both. So let's start with one at a time. What is mania?
It has to last for 1 week, doesn't it?
A week or longer, right? In which what happens?
Their mood's up, like it's elevated.
Abnormally, persistently elevated, expansive, or irritable. So right there.
So they're crazy.
Be careful with the terminology. They're manic.
They're manic. Sorry.
And then they have to have their mood's going to be abnormally, persistently elevated, expansive, or irritable. So it's going to be high. So they also have to have at least 3 signs and symptoms. Give me a few of those symptoms.
A lot of ideas.
A lot of ideas.
They go on shopping sprees for no reason.
Right.
They can go
Spend
without
money they're not supposed to. I'm sorry, go.
They can go without sleep.
Right. Decreased need for sleep. Inflated self-esteem, grandiosity, loss, and decreased need for sleep, pressured speech, flight of ideas, distractibility, psychomotor agitation, excessive involvement in pleasure-seeking activities, high risk of painful consequences. Okay? Now on the bottom, I've left that there to kind of remind you of what we're thinking about. The secondary portion, when we go below manic, something that doesn't impair the ability to function and doesn't include psychotic features. What would that be?
Depression?
Hypomanic.
Oh.
Period of abnormally persistently elevated, expansive for 4 days, includes 3 or 4, just like before. It's not as long.
I thought you said, did you just say it didn't have any manic episodes?
No, it doesn't include psychotic features.
Oh, okay.
So no hallucinations, no delusions, doesn't impair the ability to function. So there's our idea of our mania and hypomania. So what would be major depressive disorder then? What's our duration for that?
A decrease in your mood?
Duration.
Oh, duration.
It's around 2 weeks. Is it less than 2 weeks?
Greater.
2 weeks or longer.
2 weeks or longer, okay.
What are the 2 symptoms that have to be present before you look at any other symptoms?
Well, it has to be 2 weeks or longer.
Well, that's a duration, not a symptom.
Yeah. Well, they have decreased mood.
Yes, and?
And no pleasure in doing anything.
Correct. So we've got we have a decrease in mood and loss of pleasure. Now, what are some other symptoms we'd be looking for? They have to have at least 2 of these.
Decreased energy.
Decrease in energy.
Maybe sleeping all the time.
Yep.
Not eating.
Yep. Change in appetite, weight, sleep, energy.
Feeling
What else?
worthless.
Feeling worthless.
They can feel, have suicide ideas.
Suicidal ideations, plans, attempts, recurrent thoughts of death and suicide, difficult thinking, psychomotor change. And remember that when we're talking, wait. Laser. Appetite, wait, don't forget about this. This decreased energy is important, especially when we have to assess them, because remember, when we're assessing a major depressive, it may have to be done over several sessions, because they could be physically exhausted, mentally exhausted. Now, we've talked about mania. We've talked about depression. So if you combine this idea of all the way up and all the way down, what disorder do we have?
Bipolar.
Bipolar. History of mania at least once. Mood cycles between that extreme mania for at least a week and depression. Depression does follow that mania, lasts longer than the mania. And remember, with depression, we may need to have the electroconvulsive therapy to get out. Now, I put this here to remind you with hypomanics, just to remind you it does not impair that function, and it doesn't include a psychosis. So, what are our two stages, or our two classifications of bipolar?
1 and 2.
1 and 2, good. So with 1, how do you define that?
They have to have an episode of mania, don't they?
Along with what?
Depression.
What type of depression?
Major depression.
Correct. Manic mixed along with a major depressive episode. They can't survive here because there's no rest and relaxation. They are in constant exhaustion mode once they're there. We do not confront these. These guys are going a mile a minute. Speech is loud, rapid, rhyming, clanging, vulgar, grandiose, delusions, distracted, hyperactive. They can go for a week or longer without sleep. What's our second stage?
That's where they have major depression with hypomania.
There you go. Most people usually stay there. Now they can cycle between 1 and 2. They're not locked in that. Why are most people found in 2?
No clue.
Look right here. Why are most people found in 2?
Well, because in 1 they are in exhaustion.
Yeah. If they stay in 1, they're not going to survive.
Yeah,
They can't stay there for long.
Okay.
So how do we talk to somebody in 1?
We do not confront them.
We do not confront them. What would be some ways we would assess them?
Well, we need to have a calm voice and a safe environment.
Mm-hmm.
We need to isolate them, right?
Mm-hmm.
Reassurance.
Yeah. Are we going to have other people around when we're assessing them?
No.
No.
Nope. And one more thing. Allow them to control their environment. Let them feel like they're in control. So, there's our 1. What about 2? How do we talk to a 2?
Explore.
Active listening.
Active listening.
Reassurance.
Yep. Comforting, low voice, and watch for those signs and symptoms of withdrawal. Because this, again, with 2, this may take multiple sessions. They may be physically exhausted because they're at that point of major depression as well. All right. So related mood disorders. Remember, sudden chronic disorders of everybody's life, anything will alter lifestyle, can cause some mood disorders. You know, if you get diagnosis of cancer, or a family member dies, or a chronic disorder itself, you know, medically can cause issues. So if your moods are regularly low for longer than 2 weeks, but not low enough to be considered major depression, what would that be called?
Dysmic, or however you say it.
Dysthymic, yep.
Dysmic.
Now, what would be cyclothymic?
Mood cycles up and down from
Right.
their baseline.
Right, but
For more than 2 years.
correct. And they're not severe enough to be what?
Bipolar.
Correct. This is a good one for hypomania thought. All right, if it's more related to the idea of an alcohol or toxin, what disorder are we thinking?
Substance.
Yep. Let's say they have a mood disorder because they just were diagnosed with HIV. What would you think?
Mood disorder.
Mood disorder. What disorder is it when it's springtime?
Seasonal.
Seasonal, your spring version, which is your rare. Winter is your depression. Seasonal affective disorder, sad. And then you got your postpartum. We've done enough of that one. Labile mood and affect. You don't quite know what's going to happen with that. Crying. Should go away with hormones, although if it's postpartum issues, we can think about, you know, baby blues versus psychoses. All right. Let's think about etiology for a second. How is this passed along?
Yes, it can be genetic.
It is. What gives you the highest chance of getting these? Think about your first degree, 3 to 8%. Neurochemical, we're talking about mood disorders still, right? So we're thinking about bipolar, we're talking about depression, manic, hypomanic. So serotonin, loss of serotonin, depression. Norepinephrine will decrease depression, increase mania. Now over here it talks about an idea of what this is talking about, because you could still have the same amount of serotonin or norepinephrine. But this is talking about how it gets to where it needs to go. There could be too few actually released, or they could be in the synapse too short. You know, it could be too brief there.
So, question. So, if you don't have enough serotonin, then you're going to have depression?
You could.
I'm trying to get these down. I'm kind of.
Yeah, generalize these. Don't go too far into this. Just generalize that in your head, because there's multiple reasons you could do this, and we're in no way trying to become experts at this. We're trying to get the general idea. So if you had a decreased amount of serotonin, meaning that when they tried to release it there wasn't enough there, yeah, you'd think about depression. Same idea with norepinephrine. And if you had too much norepi, you'd think mania.
And too little, depression.
Yeah, they link together. Too few. This can cause other things though. If too few was released, too brief in the synapse, quick reabsorption, conditions not correct, pH changes, etc. Receptor numbers have decreased for some reason. That could be an issue as well. And your hormonal influences can cause issues on this as well. Now, with mood disorders, you know, multiple treatments. We think about suicide attempts, hospital. A lot of these suicide attempts are elderly and depressed. 1/4 of all elderly are actually completing their suicide, whereas only 1/10 of other ages actually complete. And we've heard of this many, many other times, but just to remind you, elderly have a lot of issues. Money issues, unable to complete their own ADLs, loss of dreams, loneliness, medications, feel like they're a burden. All right. For our medications and treatments, okay? First off, the stars. What medication, what chemical, if it's in your medication, tells you have to taper your doses?
Neuroepinephrine.
Norepinephrine. If it's there, you taper your dose. So, what are our 4 classifications of drugs we're talking about?
SSRI, tricyclic, atypical, and MAOI.
What about what? Talk about atypical. You forgot something about that atypical.
Atypical mixed or something.
Yes.
Is that right?
Because it's not just atypical. Atypical mixed are 2 different things, but it's an atypical mixed combination setup.
Oh, okay.
Now remember, we're going to be monitoring for complications. So, there's your SSRIs. We do not give these to schizophrenics, right?
Right.
That'd be bad because they already have serotonin. We don't want them to have more. First line of defense for our mood disorders. Higher levels of serotonin increase those serotonin levels, postsynaptic neuron, as you can see. We put it here for you. Going to block it, leaving them there. So it causes less side effects. You can increase the dosage, and you can't commit suicide. What type of medication is this?
Like Prozac?
No, that was a type of medication.
SSRI? What are you talking about? Oh, it's atypical.
Atypical. But yeah, yes, there are Prozac, as you can see. Prozac, Paxil, Zoloft, Celexa, Lexapro. Okay? Now, we talked about SSRIs. Let's go to the cyclics, the tricyclics. Tricyclics, what do you know about those before we go to that slide?
I know that if the SSRI doesn't work, you go to that one.
Correct. That's our next step. Good job. We go down to it.
That's all.
Do you know anything else about it? When would you not give it?
If they have a heart condition.
Right. One more.
Liver issues.
There you go. That's
Heart
good. Just think about these things. Little things to think about. Bad liver issues or a bad myocardial infarction history. They block reuptake of neurotransmitters. They're CNS depressants, so you think about pupil constriction. And they're conventional medications. So what does that tell you about side effects?
They have an increase of side effects.
Yep. And is it possible to overdose?
Yes.
Yep. Now, little fact on this one. It tells you a little bit more. But these are used for endogenous depression, reactive depression, depression related to alcohol, cocaine withdrawal. Watch for sedation. It's a depressant. Decreased sexual ability. It's a depressant. Dry mouth, urinary retention, tachycardia. The tri effect is how you think of a tricyclic. So besides the fact that it's a depressant, which are your signs, sedation, xerostomia, urinary retention, and blurry vision are your tricyclic effects. You've already got those. So we've done SSRIs. We've done tricyclics. What's the next one you talked about?
Atypical.
Atypical mixed. This is pretty simple. We've got some Malta effects, or Surzone, Remeron, Wellbutrin. They can help with sleep. They can help with poor appetite. They can, they have a lot of different purposes because these are many different medications and mixed of them. This picture should help in the idea of thinking about this. It's all depend on the medication of choice because they can selectively inhibit certain neurochemical transmitters, or they can inhibit all of them, or they could do just a couple of them, or one of them. Depends on the combination. But we only get to this if we have too many side effects or an inadequate response to the SSRIs. Your overdoses, your seizure, and coma. So, we've gone through all of these. Patient's not doing it. It's not working. What do we need to work on next?
Well, we have the MAOI.
Oh, no. We don't like those.
Why?
I don't know. Why don't we like these?
Oh, because they have to watch what they eat.
Oh, yeah. And what else? So there's a whole bunch of stuff we don't like about these.
Oh, these are rare to use.
Yeah, they have a high risk of interactions related to side effects, medications, both prescription and over-the-counter. There's a 2 to 4 week lag to just reach therapeutic level. And then it takes 6 weeks to wash it out of you. You have a risk of serotonin syndrome because of that. So if you want to change meds from an MAOI, you need to take almost 2 months on MAOIs or longer before you switch. Your hypertensive crisis from many foods. What chemical are we watching for is going to be triggering this issue?
Tyramine.
Tyramine. Yep.
Tyramine.
Each foods, fermented fruits, bean sprouts, salamis, and nuts, and Coffee.
That would suck.
Yup. But like I said, there's one disorder I would absolutely love to have, and that would be hypomagnesemia, because you have to eat chocolate and peanut butter. All right, serotonin syndrome. We'll be getting this later, but just to kind of remind you about this. Mental status change, confusion, agitation. ANS abnormalities, hyperthermia, tachycardia, tachypnea, chillism, diaphoresis, neuromuscular excitement, rigidity, weakness, sluggish pupils, shivering tremors, myoclonic jerks, collapse, and muscle paralysis. What was chillism?
That's excess saliva.
Yes. We know about diaphoresis, tachypnea, and all those. And remember, for serotonin syndrome, we think about what? Man.
Man?
M-A-N. Mental, A,
Oh.
neuromuscular. For serotonins, you think about man, you can think about your mental status change, your autonomic nervous system abnormalities, and your neuromuscular excitement.
Okay.
Now, we've gone through all your medications. Patient's still not doing it. We're still having issues. We're still depressed. We still have manic episodes. Still not working. What do we move on to?
The electrotherapy.
Zip, 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 zip. We do not call it shock therapy. It's not. If that patient starts having a good response, it's probably going to work for them. Why don't we give it benzos?
Gamma system.
Your gamma system. That gamma system controls your electrical system of the brain. It takes 10 days for everything to clear out and for your electrical system to go back to neutral. Why are elders a priority instead of, jump to this?
Because they have a more increased risk of suicide.
And 2 times the risk.
Their body doesn't metabolize medicine as well.
Right, so why we have to spend so much time titrating the medications, figuring out what they need, how they're going to use it, when we can simply use that. They also have that psychotic. They could have that psychotic feature. So they're a priority treatment for that reason.
The book also said that they use this for people who are severely depressed that want to commit suicide, since the medication will take so long to get through their system that they will do this and then get them on meds.
That makes sense. It's the same idea then as the elderly. Get it in there quickly, get them to a therapeutic level, and then let the medication get in there. What is the side effect of this?
Amnesia.
Mild amnesia. Is it permanent?
No.
No.
No, it fades. Now, risk factors for suicide. Females are likely to try, males are likely to succeed.
I got a question.
Absolutely.
Can we go back to that?
No. All right.
On that one, wasn't there something about like a certain time period that they were supposed to be on medicines, for the people that weren't major depressive or elderly, that there was a time period that they would do it, and then if the medications weren't working, then they would go to the ECT?
There were multiple time periods on each type of medication, especially if you look back. Let me show you. Whoop, wrong button. If we think about like this, look how long they have to be just on an MAOI before we get to that. They have to take a month to reach therapeutic levels. They have to take a month and a half to get out of this medication.
Mm-hmm.
So technically, if you think about this, we're supposed to let them go through every single one of these before we reach this.
Right.
Unless they're elderly. This is their last-ditch effort, which means we've gone through this, 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 and we don't even technically know how long they've lasted on these. This right here is 2 months easy. And they can't eat cheese. I'd be upset.
All right. Well,
Does that make sense?
Yeah. Oh, yeah, definitely. I just wanted to make sure that I don't know. I guess just saying it will help me remember that.
Yeah. Let's see. There's something. What do we need to teach them after they are complete with their electroconvulsive therapy?
Inform them when
That it can fade, like it can come back.
yeah.
Yeah, it will. I mean, this is a treatment, right?
Yeah, so it's gonna come back.
Right. We need to treat, tell them about their first signs of them coming back. So they can come back and, get maybe a little booster, or maybe if it's a major issue, they may have to go for a whole new regimen.
I thought she said that if they do it again, they have to go back through the whole stuff again.
Well, you can if it's a major issue, but if you catch it on, that's the point of catching it early. If you catch it early, like a sign, and they come in, they may not need more than a small regiment. They may not need a 6-month regiment. They may need a week regiment.
Okay.
If they go all the way through and they don't take care of themselves, they may need a full-on regimen again of a month or 2 or 3 of treatments again because they allowed it to get that bad. This is almost like thinking about a therapeutic level. Keep it up, and it makes it easier. Because this is not a cure, right?
Right.
Not necessarily, for simplistic sake.
And the first time we do this, they're in the hospital.
Right. The first time is inpatient. After that, it's outpatient treatment. So we want to make sure that they're going to respond to it. Risk factors for suicides. So, again, females are likely to try, males are likely to actually succeed at it. Females have emotions, males know how to kill themselves. So, what are Axis 4 risk factors for suicide?
Stressors.
Yes, so what are some?
Maybe financial reasons.
Financial?
Divorce.
Yeah. Loss of job. If they've been diagnosed with something recently. No? I mean, their health.
That's kind of like a combination thing there, because your Axis 3 is the actual medical problem. Axis 4 is the diagnosis. That'd be one of those hee-haw things. So, status change, major life change. So, I guess under major life change, you could put it as a stressor of a new diagnosis. Could technically fall under a major life change. I would probably stick it under medical problem.
Yeah.
Substance abuse was the only one I think you missed. Oh, and disasters. All right. Mood disorders, signs and symptoms for children. What do we got here?
Dark colors.
Dark colors. They like to color in them dark colors. What else? What else are we going to see?
They can act out.
Acting out.
Not having many friends.
Mm-hmm.
They can increase or decrease their food intake, so loss of appetite.
Appetite change.
Yeah.
What about this kid down here?
Pretending to be sick when he's really not.
Somatic complaints. May not be pretending. He may feel, mood disorder. He may feel that, general malaise, neck pains, headache, stomach ache. Nothing really wrong. It's just a mood disorder.
Because there's a bully.
Yeah, there could be a bully, or there's things that can happen. Can they talk as if they're suicide?
Yeah.
Ideations, yep. Sad, irritable, acting out. You said most of these. Isolated, sulkiness, worthless feeling. So let's do the opposite spectrum. Elders. Easily masked because of medications and possible dementia. related to, again, widowhood, illness, pain, financial issues, social isolation. Everything should be in control at this age for males, so it's an issue for them. All right, assessing these patients. Suicidal ideation, remember, we use exploring questions to find out if they have a plan. If they then have a plan, we confront to use fact to find out about facts about that plan. When are you planning on killing yourself? What are you planning on killing yourself with? On what day are you planning on killing yourself? Do you have access to the tools to kill yourself? Yada, yada, yada. Is there anything special about that day? So, threat of harm. We take every threat seriously and talk about suicide is not causation. It's actually going to decrease that risk. We perform our physical assessment first, visually, right? Then physical, mental. But place in a safe environment, remove any weapons, tools if they can harm themselves. Now, when we're assessing them, what is one-to-one assessment? Who would probably get this one-to-one?
Bipolar type 1.
High-risk patients, so they can do that, right?
Mm-hmm.
What can they do by themselves?
Nothing.
Nothing. Can't go to the bathroom?
No.
Nope.
No, they're going to hang from their panties. We're breathing the same air as them. Now, what about close observation? Can they go to the
They're
bathroom
always
alone?
in your eyesight or, you know, close by.
They can't, yeah. They're always within they're within sight, but they're at a distance. You go to the bathroom alone. The doctor has to order a change between those two. But remember, we can, get them to sign the contract for safety, recommend things to the doctor. How would we communicate with a major depressive?
Explore.
Explore.
Reassurance.
Reassure.
Observation.
They're going to be withdrawn if you're observing them.
Comfort.
Comfort them. And use your low voice. The bipolar, you use observation because they're going. You can get so much information just by watching them. They're ready to roll. Remember, with major depressives and bipolar 2, it's pretty much the same communication style because they're both, it's major depressive and bipolar 2 on this one. This one's more along the style of our manics. We're talking about the portion of bipolar 1. But remember, with major depressive, these guys are just going to sit there and lay in bed. We can observe that for a little bit, but we're going to be observing them laying in bed. And then we'd have to get them to talk. What?
I mean, they're not going to be like acting out or doing anything. They're just going to be, like you said, laying there.
Right. But we do need to watch for those signs of withdrawal when we're assessing them and trying to help with that because, again, they're going to be exhausted. So when we're assessing them, it's going to probably take a couple of sessions to assess them. But again, explore, reassure, comfort with low voice. Bipolars, observe, isolate, in calming effect, but do not confront. All right, when we're assessing these patients, we need familial and personal history. Who do we get the information from?
Family.
So you're going to assume they cannot give their own information?
Wait, who'd you ask for?
We're getting assessment on this patient.
On depression?
We're assessing this patient. Who do we get the history from?
Well, depends on which one they are. If they're manic.
Yeah, what?
Just in general, assessing the depression.
Depression patient.
Oh, I see what you're saying. Excuse me. I'm sorry.
I'm sorry. Yeah, I didn't understand what type of patient you were talking about.
Sorry.
It's okay.
Yeah,
We're going to get the information from them.
Yeah. Now, it may require us to go to the family for information, but never assume that we can't get our information from the patient first.
Right.
No matter what the disorder, unless it specifically says it, we can at least ask the patient.
I thought there was something that she said that there's some type of something.
There is one. I'm saying, unless it's specific, most of the time we can assume to.
What is that specific one? Do you remember?
I was just thinking about that. I was like, which one was that?
There is one. We'll get to it. But
yep. But like this one, like when we get to even when we're talking about schizophrenia, if they're a long-term schizophrenic, they know they're long-term schizophrenic. They can tell you the drugs, what they do, what happens, their hallucinations, what their delusions are, and I mean how it all works because they've been through the gamut. I know one, catatonic patients.
Those are your waxy. Like,
the ones who aren't going to talk because
right.
they're probably in a coma-like state. So you probably have to ask the family.
Right.
Remember, again, take several periods related to the exhaustion, being overwhelmed. Their general appearance, you're thinking sad, ill, psychomotor retardation, latency of response, but more than 30 seconds. Now, they can also be agitated when they're actually overwhelmed. Anhedonia, sure, no pleasure term. They ruminate, repeatedly going over the same thoughts. The idea of care, remember they're exhausted and overwhelmed, so provide physical care, hygiene, basic needs, ADLs. We have our contract for safety with them, no harm to self or others. We may have to go to a one-to-one care if they refuse to sign the contract. All right, restraints. If we have to call the doctor and they order restraints, how quickly does that doctor have to come down to see that patient? 30 minutes, yeah. How often do we have to reassess this patient?
Every 15 minutes.
Right, we have to remove it, make sure there's no damage, there's no actual harm to the patient. How often does that order have to be renewed?
Every 2 hours.
So how often should that doctor be seeing this patient?
Every 2 hours.
Does that normally happen?
No.
No. And then don't forget, 4 side rails up, extremity bands, lap bands, chemical. There's a lot of different ways of restraining a patient. 3 bars up and a table in the way is considered a restraint because that still counts as the 4th bar. Your risky behaviors, impulsive acts, Russian roulette, death-defying acts, cutters, eating, springs off the beds, but there also could be no warning. People kill themselves. They hide emotions, especially because suicide is a private matter. They don't want you to talk about it because if they find out that they may not do it. So they may show no warning. Interventions for these issues, authoritative role, give them a safe environment, and create a support system for this patient. So, family member has committed suicide. How is this family going to respond?
Could be angry.
At who?
Themselves.
Themselves.
Well, also the one that killed themselves.
Yes, at the completionist.
And if they think that if they can do it, so can they.
Yeah. If he can do it, so can I. So what do we need to get them to start thinking about?
That it wasn't their fault, that the patient had issues.
Mm-hmm. The best thing they could have done is kept the patient safe. If they kept the patient safe and they still did it, they did everything they could to help them. And the family needs to talk about it. They need to, all be understanding of what's going on in each other's feelings. Now, the nurse who's been working with this patient is also may have some feelings. What feelings would that nurse be feeling?
That she didn't keep them safe.
Yeah. They may have failed the patient, the family. Should have noticed the signs and symptoms. Remember, they may blame themselves. The client will hide their true feelings. We need to, we have education and special training to help get through that. We don't catch it all the time. All right. Let's jump to something a little more colorful. Sherry, if I were to push a drug into you and you said no and you died from it, what type of euthanasia would that be?
Murder.
No, that's not that's not the right term.
I know. It's involuntary.
Involuntary euthanasia and
I don't know.
active.
Oh, okay.
Conscious act results in death. Fun little terms here. So think about your idea of active versus passive and involuntary versus involuntary. So what did Kevorkian do? I think you're old enough to remember Kevorkian.
He helped people commit suicide.
Yeah. He used active and he used voluntary, but there were laws against it. Well, there were no laws against it, there were no laws for it at the time. So let's say I'm in a nursing home. The nursing home has, you know, a DNR order on it. Patient begins dying. They give pain medications, and the patient could be brought back probably by you know, CPR, but they decide not to, and the patient is allowed to pass. What would you have there?
Passive.
Passive.
And
Voluntary.
voluntary, because they signed a DNR. Yay!
Yay!
You just went through that full slideshow. We just spent an hour on that one. Do you want to take a 5-minute break?
Sure.
All right, let's take 5. Did you have any questions? Does anybody have any questions while we're taking our 5?
Nope. I don't.
Casey, Sherry.
I'm good.
Okay. Dun, dun, dun. Do, 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 do. Boom, boom, boom. Okay. All right. Hello.
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 Welcome back. By the way, just to show you what I was using this morning with you, what we'll be looking at later while we're online, but it'll probably be later on this evening, Jamie. This is one of the charts I was using when we were studying this morning.
Okay.
So that's the one I put up this morning as well on Facebook.
Okay.
So
Cool.
all right. So it's time for our favorite time of the hour.
Oh, is it question time?
It's time for questions on mood disorders.
Yay.
Yeah, especially because it's all right here in my handy-dandy psych exam. Well, bam! Look at that, 56 pages and counting. Woo!
Yay.
I wonder how many questions we do in nursing school. My head hurts from that thought. Now, we'll go through these. If any of them don't really pertain to us, I will delete them. But there's only 3 of you, which means we get to go through them one at a time.
Oh gosh.
All right. We just went through all the mood, so let's go through it. This should make it easier. Which nursing diagnosis supports the psychoanalytic theory of development of major depressive disorder? Social isolation related to self-directed anger. Low self-esteem related to learned helplessness. Risk for suicide related to neurochemical imbalance. Or imbalanced nutrition less than body requirements related to weakness.
2 or 4? I don't know.
Whoa.
I think 3.
I think 1 or 3.
Oh Lord, I have no clue.
Go with 3.
Okay, you guys are in a great fast mood. Let's make sure we're reading questions. Development of major depressive disorder. Social isolation.
So it's 1.
Yes.
Okay, so the keyword's development.
Yes.
Okay.
Not in it.
They're
Looking
developed.
for what is psychoanalytic theory is causing the development of major depressive disorder. Social isolation. The only 2 that should have made pop up in your head would have been 1 and 2. 2 would have been based on the learning theory. But again, not as important for us, so we're gonna go think. Jamie, which client statement is evidence of the etiology of major depressive disorder from a genetic perspective? My maternal grandmother was diagnosed with bipolar affective disorder. My mood is a 7 of 10, and I won't harm myself or others. I'm so angry that my father left our family when I was 6. I just can't do anything right. I am worthless.
So this is a genetic
Okay.
1?
Yep, that's the only etiology dealing with genetics.
Yeah.
All right, Casey.
I'm still reading it. Whenever someone talks, they pop up on the screen.
Oh, I'm sorry. We'll make this easy on you.
Okay.
Boom.
Awesome.
The other thing you can do is click my face, and it will lock onto that face.
Okay.
During an intake assessment, which client statement is evidence of the etiology of major depressive disorder from an object loss? Whoa, hold on. Which statement about the development of bipolar disorders from the biochemical perspective? Family studies have shown that if one parent is diagnosed with bipolar, the risk of the child with bipolar disorder is around 28. In bipolar disorder, there may be possible alterations in normal electrolyte transfer across cell membranes, resulting in elevated levels of intracellular calcium and sodium. Magnetic resonance imaging studies have revealed enlarged third ventricles, subcortical white matter, periventricular hyperintensity in individuals diagnosed with bipolar, or twin studies have indicated a concordant rate among monozygotic of 60 to 80.
Oh, Lord. 3? I don't know. Which statement about this?
The answer on this one is 2. The idea of alterations in electrolyte transfer across cell membranes.
Yeah, I would fail this test.
Yeah, but we didn't have to.
That one was hard.
That one was hard. And we'll leave that one on there just because the idea of electrolyte transfer, just something to review on there. And I'll read it to you. Alterations in normal electrolyte transfer across cell membranes results in elevated level of intracellular calcium and sodium. Oh, that's the example. This is a throwaway question because this is the only biochemical answer.
That's true.
So this is one of the ones you're like, I have no idea. What is it asking? Biochemical? Okay, it's family? No. Magnetic? No, that's anatomy. Twin studies done, too. You may not know what it means, but you can figure out that those aren't it.
Right.
Jerry, which statement describes a major difference between a client diagnosed with major depressive and a client diagnosed with dysthymic disorder? A client diagnosed with dysthymic is at higher risk for suicide. A client diagnosed with dysthymic may experience psychotic features. A client diagnosed with dysthymic disorder experiences excessive guilt. A client diagnosed with dysthymic disorder has symptoms for at least 2 years. Weeks.
I was about to say, I would pick number 4 if it said weeks. So, 4.
Yes. Jamie. Client expresses frustration and hostility towards the nursing staff regarding the lack of care his or her recently deceased parent received. According to Kubler-Ross, which state of grief is this client experiencing? Well, you can try it.
I don't even know what Kubler-Ross.
Well, give it a shot. Anger, disequilibrium, developing awareness, or bargaining.
Anger.
Yeah, that one wasn't hard.
Gosh. Oh, 8 and 7. I was like, look at that long answer.
Casey. A client plans and follows through with the wake and burial of a child lost in an automobile accident. Using Engel's model of normal grief response, we're going to delete this. Which charting entry most accurately documents a client's mood? Client expresses an elevation in mood. Client appears euphoric and interacting with others. Client isolates self and is tearful most of the day. The client rates mood a 2 of 10.
I mean, I've never rated a patient's mood, but I've also never worked at a psych hospital. I don't know. Documents is the, yeah, that's the key word. I mean, would it be the rate one?
Yep. All the other ones use terminology.
Right.
We're rating it as a number.
Okay.
I didn't know we rated it either.
Oh, yeah. She didn't mention anything, but yeah, you rate things.
Okay.
We med-surg, we rate pain. Psych, we rate mood.
Okay.
I knew pain, but I didn't know psych.
You learned something.
Sherry, which client is highest risk for major depressive disorder? 24-year-old married woman. 64-year-old single woman. 30-year-old single man. 74-year-old married man.
Oh, I can't remember all my numbers.
That's okay.
Number 2. And I'm just guessing.
No, the answer actually is 1.
1.
And the only reason it's not 4, though, is because of his marital status. He still has somebody.
That's why I went with the older woman that's single.
Yeah, this says research indicates there's a higher rate of depression disorders in young and old, not older, married, not single women compared with other clients. That one's a bit of an issue, but Jamie. A client is admitted to an inpatient psychiatric unit with a diagnosis of major depressive disorder. Which of the following data would the nurse expect to assess? Select all that apply. So it's inpatient psychiatric unit, major depressive. We're looking for assessments. Loss of interest in almost all activities. And anhedonia. A change of more than 5% of body weight in a month. Fluctuation between increased energy and loss of energy. Psychomotor retardation, agitation, insomnia, or hypersomnia.
All of them?
Mm-mm.
Okay.
One of them's wrong.
One of them is, would it be the body weight?
3.
3?
They're depressed. Bleh.
They're not going to have any energy anyways.
Yeah, remember, they may have some slight irritability, but they're not going to have energy.
Okay. Plus all applies. I hate those.
Casey, I think you're there. Maybe not. Oh, I think Casey's taking care of her child. Sherry, you get to jump again. Client is exhibiting behavioral symptoms of depression. Which charting entry would appropriately document these symptoms? Rate moods is 4 of 10. Expresses thoughts of poor self-esteem during group. Became irritable and agitated on walking. Rates anxiety is 2 of 10 after receiving Ativan.
Okay, client is exhibiting behavioral symptoms. Three.
Yes.
Because I was looking for behavioral stuff.
Yes. Jamie, which symptom is an example of a physiologic alteration exhibited by clients diagnosed with moderate depression? There we go. Which symptom is an example of an affective alteration exhibited by clients diagnosed with severe depression? Apathy, somatic delusion, difficulty falling asleep, or social isolation?
What's apathy again?
Defined as indifference, insensibility, and lack of emotion.
Four.
The answer is 1 because 4 is behavioral.
4 is behavioral. Oh, okay.
Sherry, the major depressive disorder would be most difficult to detect in which of the following? 5-year-old girl, 13-year-old boy, 25-year-old woman, a 75-year-old man.
75-year-old man.
Nope.
I thought their age hid. Oh. Okay, what is
Their
it?
age does hide it, but which one would be the most difficult?
Most difficult. Well, the 5-year-old.
Angst. I'm depressed. Cut my wrists.
13.
Oh.
For a teenage boy. Jamie. Which is the key to understanding if a child or adolescent is experiencing an underlying depressive disorder? Irritability with authority, being uninterested in school, a change in behavior over a 2-week period, being insecure at social gathering.
Which is the key to understanding the child underlying. 3?
Yes. Yes.
Yes.
Okay. Casey, all you have to do is unmute yourself when you want to answer the question, and you can mute yourself again for the background music, and it's fine. We have plenty of people that have to do that. Go Jamie, knowing stuff. 17. Which nursing charting entry is documented of a behavioral symptom of mania? Thoughts fragmented, flat of ideas noted. Mood euphoric and expansive, rates mood at 10 of 10. Pacing halts throughout the day, exhibits poor impulse control. Easily distracted, unable to focus on goals.
Whose is this?
Casey.
I would say 1. No, 2.
2 is affective, not behavioral.
Oh.
Okay.
I did
What are
the same
behavioral symptoms of mania? Try again. That should make it really easy.
I don't know.
How are they acting?
3.
Okay. Okay.
They're moving, they're moving, they're moving.
These are the things that I'm horrible with because I can't.
That's why we do these. Makes us think about these. She may not answer these questions in this way, but at the very least, we get to think about them in this way. So if we see the word behavioral, we'll be like, underline. We see the word, social, underline. We'll understand the difference between those terms. We won't get lost in that. Sherry. A nurse on an inpatient psychiatric unit receives report at 1,500 hours. Which client would need to be assessed first? A client on one-to-one status because of active suicidal ideations. A client pacing the hall, experiencing irritability, flight of ideas. Client diagnosed with hypomania, monopolizing time in the milieu. Client with a history of mania who is being discharged in the morning.
Would it be 1? Because they're talking about suicide?
No, actually. They're on one-to-one status, meaning somebody's there with them.
Oh.
Okay, so 2.
2, yes. Safety issue. Most assaultive behaviors. Now, with 1, it says, one-to-one observation status is being monitored constantly. It would not require immediate assessment because somebody's with them.
Okay, because they are being watched.
Yep. You're receiving a report, which means you're probably not the one watching them.
Okay.
Versus the client pacing the hall, experiencing irritability, flight of ideas, safety issue. All right, Jamie. A nurse is planning to teach about appropriate coping skills. The nurse would expect which client to be at the highest level of readiness to participate in this instruction. A newly admitted client with anxiety of 8 of 10 erasing thoughts. A client admitted 6 days ago for manic episode refusing to take meds. A newly admitted client experiencing suicidal ideations with a plan to overdose. Or a client admitted 6 days ago for suicidal ideations following a depressive episode.
Okay, let me reread it. Oh, man. Okay. Nurse is planning to teach about appropriate coping skills. The nurse would expect which client to be at highest level of readiness to participate in this instruction. Four,
Boom!
because The other two, a newly admitted, you can throw that out because you can't teach coping right away, right?
Right. Well, you can,
Well, yeah, but they're
but
not.
their anxiety's 8.
Yeah, I mean, you can, but it's not going to really do any good.
Right. And everything else is, they've got a plan. Episode, refusing to take meds. They're manic. Good luck. Suicide with a plan. Anxious. And their suicidal ideation 6 days ago.
Right.
All right. Casey. Moving on to a new setting of questions. A newly admitted client has been diagnosed with major depression. Which nursing diagnosis takes priority? Social isolation, related to poor med, as evidenced by refusing visits from family. Poor mood, excuse me. Self-care deficit, related to hopelessness, as evidenced by not taking a bath for 2 weeks. Anxiety, related to hospitalization, as evidenced by anxiety rating of 8 of 10. Or risk for self-directed violence, related to depressed mood.
4.
Yes, these psych can use risk as a priority.
Okay.
Sherry. The client's outcome states the client will make a plan to take control of one's life situation by discharge. Which nursing diagnosis documents the client's problem that this outcome addresses? Impaired social interaction, powerlessness, knowledge deficit, dysfunctional grieving.
Two?
Yes, they don't have power, so let's have them gain power. Jamie looks so happy to be here this morning.
I'm thrilled.
Yes, everybody loves this morning.
I'm even getting my nails painted while I'm doing it.
Oh, I might have to have somebody do my nails.
Mom's up here doing them for me.
Hi, Mom. Will you do my nails?
Make her answer some questions.
She has been. She's been whispering to me.
She should answer some questions. Which nursing diagnosis takes priority for a client immediately after electroconvulsive therapy? Risk for injury related to altered mental status. Impaired social interaction related to confusion. Activity intolerance related to weakness. Chronic confusion related to side effect of ECT.
Is it mine?
Yup.
Oh, 4.
Yes. Your most common thing is what with an ECT?
Confusion or not remembering things.
Well, your mild amnesia, which
Right.
is your idea of chronic confusion. Like, what's going on? All right. Casey. Client diagnosed with major depressive has been newly admitted to an inpatient psychiatric unit. The client has a history of 2 suicide attempts by hanging. Which nursing diagnosis takes priority? Risk for violence directed at others related to anger turned outward. Social isolation related to depressed mood. Risk for suicide related to history of attempts, or hopelessness related to multiple suicide attempts.
3.
Yay, that one was a gimme.
Yeah.
I like
That's not
gimmies.
fair.
It's all right. We're almost to lightning round. You'll like lightning round. Sherry, client diagnosed with cyclothymia, is newly admitted to an inpatient psychiatric unit. Client has a history of irritability and grandiosity and is currently sleeping 2 hours a night. It's me. Which nursing diagnosis takes priority? Altered thought process related to biochemical alterations. Social isolation related to grandiosity. Disturbed sleep pattern related to agitation. Or risk for violence self-directed related to depressive symptoms.
Let me read through again.
Mm-hmm.
3.
Yes. Disturbed sleep patterns. Remember, you can't stay in exhaustion forever. Cyclothymic is not bipolar. It's not good enough to be bipolar. It's not strong enough to be bipolar. Defined as time-limited disruption of sleep among amount and quantity. Because you're only sleeping 2 hours a night, the client is meeting the defining characteristics of the nursing diagnosis of disturbed sleep. This is usually due to excessive hyperactivity and agitation. There is that. Jamie, a client diagnosed with bipolar disorder and experiencing a manic episode is newly admitted to the inpatient psychiatric unit, which nursing diagnosis is a priority at this time. Risk for violence, other directed related to poor impulse control, altered thought process related to hallucinations, social isolation related to manic excitement, low self-esteem related to guilt about promiscuity.
3.
No.
I thought we isolate them.
What's the priority?
Violence.
Risk for violence,
1.
other directed related to poor impulse control. Safety, safety, safety.
Safety, safety, safety. Okay.
Safety, safety.
But social isolation we do, but it's not.
Yes, but that is not our
It's
priority.
the correct answer, but it's not the right answer.
There you go. Casey. You get the last one before we play lightning round. Client admitted with major depressive disorder has a nursing diagnosis of ineffective sleep pattern related to aches and pains, which is an appropriate short-term outcome for this client. Client will express feeling rested on awakening. Client will rate pain level at or below 4 of 10. Client will sleep 6 to 8 hours at night by day 5. Client will maintain a steady sleep pattern while hospitalized.
What's the next time after ABC time?
I'm going back and forth between 1 and 3.
Mail time, of course. And then we go somewhere.
Effective sleep pattern, related to aches and pains. 3.
3, because 1 is not measurable.
Right. The only thing that was thrown, I mean, I guess I was thinking, well, awakening is kind of measurable, but
No, awakening is, but feeling rested is not.
true.
6 to 8 hours is measurable.
That's right. Okay. Awesome.
All right. Boop, boop, boop. Oh, it's Blue's Clues.
Yeah,
All right.
sorry.
Let's jump around, lightning round. Ooh, 48. That sounds like fun. Let's see. 48. A nursing instructor is teaching about the cause of mood disorders. Do you all get to answer these now? Which statement by a nursing student best indicates an understanding of the etiology of mood disorders? When clients experience loss, they learn that it is inevitable and become hopeless and helpless. There are alterations in the neurochemicals, such as serotonin, which cause the client's symptoms. Evidence continues to support multiple causations related to an individual's susceptibility to mood symptoms. There is a genetic component affecting development of mood disorders.
3.
4.
3. Evidence continues to support multiple causations. I'm sad because of divorce. I'm sad because of genetics. Yada, yada, yada. All right. Lightning round. Some stay dry. Oh, drugs. Select all that apply drugs.
I only recognize like one of those drugs.
Good, it'll be fun. Which of the following meds may be administered before ECT? Robinal, phenethal, anectine, Ativan, Depakote.
2 and 5.
Oh, you got one of them.
Is 1 one of them?
Yes.
Is it 1 and 5? Or 1 and 2?
1, 2, and 3.
1, 2, and 3.
4 is a depressant, which is interfering with seizure activity, so you wouldn't want to give it. 5 is an anticonvulsant, which will interfere with seizure activity, so you wouldn't want to give it. Because we're dealing with that. So if you think about our ECT, we don't want to give anything like a benzo, right?
Right.
We don't want to give anything like an anticonvulsant or a CNS depressant that's going to alter that. Client diagnosed with major depressive is newly prescribed Zoloft. Which of the following teaching points would the nurse review with the client? Select all that apply. Monitor the client for suicidal ideations related to depressed mood.
I know
Discuss the
2.
need to take medications even when symptoms improve. Instruct the client about the risks of abruptly stopping the meds. Alert the client to risk of dry mouth, sedation, nausea, sexual side effects. Remind the client that medication full effects do not occur for 4 to 6 weeks.
2, 3, and 4? I don't know.
I say 2, 3, 4, and 5.
Boom! Out the park with that one.
Yay!
Oh, we can go into that one if you want. Lightning round. Let's see. Here we go. 33. Client denying suicidal ideations. Comes to the emergency department complaining about insomnia, irritability, anorexia, and depressed mood. Which intervention would the nurse implement first? Request a psychiatric consult. Complete a thorough physical exam assessment, including labs. Remove all hazardous materials from the environment. Place the client on one-to-one observation.
2.
2.
2. Physical assessment. First. Big old yellow slide I made.
But yeah, but my argument there would be safety, because
He's denying suicide. He came into the ER.
oh, denying. Okay, I missed that word.
Yeah. I was like, somebody walks in he can't sleep, he's irritable, he's anxious, and he's depressed. Why would you do anything else?
Yeah, that would be the stupid question I would miss, because I missed the word deny.
A client diagnosed with major depressive has a nursing diagnosis of low self-esteem related to negative view of self. Which cognitive intervention by the nurse would be appropriate to deal with this client's problem? Promote attendance in group therapy to assist the client to socialize. Teach assertiveness skills by role-playing situations. Encourage the client to journal to uncover underlying feelings, or focus on strengths and accomplishment to minimize failures.
4.
I agree, 3.
That'd be intrapersonal. Cognitive would be 4. Focus on strengths and accomplishments.
So it's 4.
Yes.
Yay!
35. We'll do a couple more and then we'll be good. A newly admitted client diagnosed with major depressive disorder isolates self in a room and stares out the window. Which nursing intervention would be the most appropriate to implement initially when establishing a nurse client? I notice you're looking out the window. Sit with the client and offer self frequently. Notify the client of group therapy schedule. Introduce the client to others on the unit. Help the client to identify stressors of life that precipitate life crisis.
One.
1,
Yeah.
3, 4. Yes, 1.
Do you like how he's using silence to see if we're going to change our answer?
One more. Client diagnosed with major depressive is considering ECT. Which client teaching should the nurse prioritize? Empathize with the client about fears regarding ECT. Monitor for any cardiac alterations to avoid possible negative outcomes. Discuss with the client and family expected short-term memory loss. Inform the client that injury related to induced seizure commonly occurs.
3.
Yay! All right. And just to remind us about what we're looking at, yeah. All right, we got through that one. Yes, we'll stop this one here. We will record another one. We'll do a review on the basics of psychiatric, and we're going to go through each one. Schizophrenia, we're going to make sure we can do one on every single one of these. So let me stop this here.